No, I'm just double checking. We're just waiting for some people coming in. I just want to make sure that everyone can hear my audio. If you could just give me a thumbs up or a hello, that would be great. Thank you. We'll just wait for a couple more people and we'll get started quickly. Hello, Barbara. It's always nice to get that connection when you're on a screen.
Yes, it's so true.
Okay, I think I'm just checking on time. Why don't we go ahead with the intro? I would like to thank everyone for their time and joining us on our first of 6 pelvic floor lectures. Ellen Wedemire, formerly known as Rossiter, has compiled lots of information for everyone to see. A little background on Ellen. She's been with Active Sports Therapy since 2012, believe it or not. She worked at the clinic as a kinesiology student for many years and then shifted into the physiotherapy role when she was able to come, and we were very excited to hear that Ellen was coming for that. And you've been, I think, for 3 years, is that right, Ellen?
Yep.
Yeah. Yeah. So we're so happy to have everyone here this evening, and we're also very happy to have Ellen start the series on invading spaces. So I'm going to pass it over to Ellen for some housekeeping on if you have any questions. I think Ellen will follow up with that.
Yes.
And I will slowly let people in and mute myself.
Perfect. Thank you so much, Renee.
Thanks, Ellen.
We'll start on this slide. Let's see if it works. There we go. On this slide here. Welcome, everyone. I'm so excited to be able to share knowledge with everyone. As Renee said, I'm a physio at Active Sports Therapy. I am both a stereotypical physio, ankles, knees, and backs, but I also practice in the pelvic floor. So I've done a whole bunch of training on pelvic floor specific. And in that training, I realized how much information is out there for people, especially women. I'm partial to that, but everyone that just isn't there. So that's where this whole kind of series has come from. In this case, we are going to be talking about the prolapse in particular, but we're going to get some other kind of pelvic floor stuff going as well, since everything is connected. Now, before we start, this is really important. I welcome questions at any time, but this can be a bit of a sensitive topic for a lot of people. So what we're going to ask is that for any questions, feel free to type them in the chat at any point. Renee is going to be kind of monitoring that for me. That way we can answer questions as we go. Now, if your question was in the chat box and I'm answering it and there's extra information, or maybe I'm not reading the question correctly, feel free to unmute yourself if you're willing and just kind of clarify what you're looking for. But on that note, since it's a little bit more sensitive, if you'd like to remain anonymous in order to ask anonymous questions, it's very doable on Zoom. You can change your screen name. So for some people, those are on the computer. I know what you're doing. I've never used Zoom on the phone, but if you're on the computer, you can go up to the right on those 3 dots and hit rename. That name is what's going to come up in the chat box. So if you want to change it to anonymous or Joe or whatever you want, that's what's going to come up on the chat. So no one needs to know what question you're asking, just in case you're a little bit embarrassed or just not comfortable asking that question. I really want everyone to feel like they're getting a lot from this presentation and really learning a lot. So please ask away. Now we'll get into it. So today we're going to be talking about prolapse, more specifically pelvic organ prolapse. So prolapse itself is basically just organs that are kind of dropping or not staying in the place that they're originally designed for, or if you do a quick Google, say the drooping or dropping of organs. But in this case, we're looking at pelvic organs in particular. So with prolapse, it is an organ that is basically creating a protrusion at or near the vaginal opening. So what that means is one of the surrounding organs, the bladder, the uterus, or the rectum in particular from this, will actually start to invade into that vaginal space, which is why I call this invading spaces. Now, with prolapse, it's really important, especially if people have either been diagnosed with prolapse and don't really know what's going on. It can sound like something is basically busting through the wall, and that's not actually the case. If we think of the vagina or the vaginal canal, it's not really super solid like you would think of maybe a toilet paper roll, where if you wanted to get in there, you would really have to hammer on it. You have to create a hole in it in order for something to get in. This is more like an elastic or a rubber glove, or I've had a patient describe it as kind of a trampoline. So if you have your vaginal canal and something is pressing on it, it simply takes away that space. You can see it better this way. Takes away that space. So you can see in this picture in particular, this is looking at a bladder prolapse. You can see we have our vaginal canal right through here. And then the bladder is basically dropping down. It's a little bit droopy on this side. And you can see how it's taking away that space of the vagina. That is a pelvic organ prolapse. So it's actually moving in and invading that space. Now, this presentation is going to be specifically for those with a vagina. And that is simply because that's what the research is that I'll kind of be talking on. You can technically get other prolapse, for example, rectal prolapse, where the rectum is actually going through the anus or dropping in and around the anus. That is not what we're talking about today. We're specifically talking about it going into that vaginal space. Now, to get kind of further into it, we have the three different types. We have the bladder, the uterus, and the rectum. And that is basically all the different sides of the vagina. So if we are considering the vagina basically right in the middle of that pelvis or that pelvic floor, we have our bladder that sits right in front of it. So you can see that on this picture. We have our vagina, bladder sitting right in front of it. We have the rectum right behind it, and then we have the uterus that sits on top of it. And so uterus and cervix. So any of those things, since we have such a stretchy vaginal wall, can start to push into that wall. So the bladder, if it is pushing in front, it's called the cystocele. You don't have to know that. We have the rectum pushing in from behind, and we have the uterus pushing in from above. Anyone can have one or all of these things. You can see just, these are some really good pictures of kind of that depiction of that bladder kind of drooping in, and this would be pushing into the vaginal space. We have the uterus that's dropping down. So if you compare something like this to the uterus down here, we have a significantly smaller vaginal canal space. And then in this case, we have this poor rectum starting to push in. Now we would feel a lot of heaviness or pressure here. But if that was to get worse, it's going to start invading into this space as well. Now, again, kind of on that kind of physiological and anatomical idea, there are different grades of prolapse. And this can be, I guess any of those previous prolapses that I discussed can be graded as a 1, 2, 3, or 4. So basically the grading system works by how far is this organ into the vaginal canal, and basically how far is it away from coming out of the vagina. So again, if I'm saying out of the vagina, it is going to be the hole and then the vaginal wall, and it's the vaginal wall with that organ coming through. So we're never busting holes into the vagina, it's all coming with it. So we have our grade 1, which is basically just coming down. Now this is specific to uterine prolapse, but similar grading for the others. And you can see that a grade 1 is simply just coming down the tiniest bit. So we're comparing here to here. I can honestly say that most, if not all, moms who have given birth, whether it's through cesarean or vaginal birth, tend to have at least a grade 1 of prolapse. And that's just because you were carrying a baby, everything got shifted around, we end up with different pressures. So grade 1 is something that's just a teeny tiny bit lower than it's supposed to be, or into the vaginal canal more than it's supposed to be. Grade 2 means that everything is still completely inside, but it's pretty darn close to the opening. So that is something where you might kind of feel a little bit of mass when you are feeling down there, but it's not so much that it is coming outside of our vaginal opening. Grade 3 means that it has made its way past the vaginal opening. You can see here. So if this is our opening here, or in this case, it's just kind of peeking through. And then grade 4 is total inversion. So that is a lot of this organ is outside of the body. Now, who does POP affect? Again, that's pelvic organ prolapse. If I refer to POP, 50% of women who have had children have at least some degree of prolapse or pelvic organ prolapse. And this incidence tends to increase with age. So if you had a baby in your early 30s or late 20s or anything around there, you may just have a grade 1, not know about it. And then as life goes on, we can see that kind of worsening, or and since it's worsening, then you're getting those symptoms. So the incidence tends to increase. But there are also 2%, according to many studies, of women who have not had children that still have prolapse. So having kids is not the only kind of risk factor or relationship, but since we're kind of reorganizing all of our insides when we're carrying babies, and then that downward pressure, especially if you're having a vaginal birth or lack of support from the core in a cesarean, can increase the incidence of having some sort of prolapse. Now, what's interesting is that you can have changes over time, whether or not you do anything about it. So there was a study that looked at a whole bunch of women of varying degrees of prolapse, of varying types of prolapse, and just watched them over 5 years. No treatment, good or bad, nothing like that. They're just kind of monitoring to see what happens. And for 47% of them, there was no change, which means that if you're having issues right now, there's a almost 50% chance that nothing would happen whether or not you have treatment. 13% regressed, which is a good thing. So it went back a grade, which is amazing. I wouldn't be surprised if those people changed their lifestyle in that time, maybe just did some full body workouts, got in shape, something like that, so that their general strength increased. But either way, fantastic for them. But 40% got worse. And so that is kind of where we're talking about kind of preventative work, or using some sort of treatment to try and help or prevent that further progression of the prolapse. All right. Any questions so far, Renee? I think we're good. Lovely. Okay. Interrupt me if anything comes up. So this is more important to what you're experiencing. We already know what prolapse is, but what does it mean for you? So firstly, we have our symptoms. These two on this screen are going to be the most common symptoms that people are noticing, and that is some sort of actual protrusion into the space, or a feeling of pressure. So in terms of that protrusion, you might be feeling full in through kind of that lower pelvis area. You might feel some bulging. That's especially noticed, say, if you are wiping after you pee or have bowel movement and you actually feel tissue either coming out, or it feels like there's bulging in through that lower area. There's a good chance that it's prolapse related, if not some sort of prolapse. But a lot of people might start to notice it even before the pressure or anything like that. They might feel it during any kind of insertion. So that could be some sort of sexual encounter that involves insertion. It might feel like if you have a partner or a toy or anything like that, it might feel like it can't get as deep, or it's bumping up against something that wasn't there before. There's a chance that that is now an organ that is in that area that wasn't there before. Some people also notice it if they're inserting tampons. Or on that note, a cup, some sort of menstrual product. If all of a sudden you're having to change your angle or something weird is going on where you're not able to insert the same way, there's a chance that that could be part of prolapse as well. Now, the feeling of pressure is usually the number one symptom that people notice before anything else. And that is just this weird downward pressure in the perineal region. A lot of people will notice this and just kind of brush it off until it becomes a recurring frustration. And I've also heard from a lot of newer moms, kind of in those first few years when they're chasing their toddlers around, that is where they'll start to first kind of notice that downward pressure. Generally, that pressure is going to be way worse if you are standing or jumping, skipping. Trampolines tend to be one of the first times that people notice something, but having that downward force. But it is much better when it's lying down. So a lot of people notice that it doesn't happen in the morning, they don't notice it, but as the day goes on, it gets worse. So that could be a symptom related to prolapse. So this is our lovely picture of potentially what I can see if I'm assessing a prolapse. So here we just have this vaginal canal, nothing in the way, but with a pelvic organ prolapse, I would guess this is a uterine one because this would be your cervix, but this is kind of the general gist. So if you're up for it and you're feeling kind of weird pressure or something's going on, you can always grab a mirror. And if you see something like this in a standing position, then that is an organ that is a little bit lower than it's supposed to be. And there's ways that we can kind of sort that out. All right, other symptoms. Oh, there we go. That aren't quite as obvious, but definitely related, or at least could be related to prolapse, are urinary retention and urinary incontinence. And the reason for this is because the bladder is no longer in an optimal position. So urinary retention is, you know you have to pee, you feel like you have to pee, you get to the toilet, you are ready to go, and nothing is coming out, or it's dribbling slowly, or it's just not happening for you. And that can be because the bladder itself isn't in a great position to let you empty. So if you see on this second picture right here, this is the same as the other ones, but now flipped around. So this is now the front of the person. So we have our bladder that, right, when it's good, everything is above the urethra. So the urine will come from the kidneys, come down, hang out in the bladder, and then go through the urethra out. So this is all fine and dandy because gravity is very helpful. But if all of a sudden the prolapse is tilted on its side, some parts are lower down, if we have urine that's right here, it's a little bit trickier to get it up and over this urethra to get out. Now, the bladder does have its own muscle, so it does have the ability to kind of contract and get it out of there. It's just a lot tougher. Now, urinary incontinence can happen, which is basically the release of urine when you're not intending for it to happen. If things are a little bit worse, it can put everything into a position that is not optimal and the body doesn't have very much control over the situation. And so you can start to get incontinence as well. That is actually related to a prolapse. Same thing for the rectum. So changes in bowel function can be very much related to a rectal prolapse where it's just kind of pushing in. And again, if we think of the picture that was at the very beginning, there is an example of the rectum looking a heck of a lot like this bladder where it is kind of down here. So again, if we have fecal matter that has to go down and then back up, it's a little bit trickier. So we can have a little bit of retention. Now, something to note is that constipation is not caused by prolapse. It is a separate thing, but it can very much increase our incidence or aggravate a current prolapse. Because if you think of when we're constipated, everything is just kind of bulged up there and we're trying to get it out. So we use a lot of downward force. So if you already have a prolapse, then adding downward force isn't incredibly helpful and it can aggravate symptoms. So I'll say it here, I'm going to say it a million more times. If you have a prolapse and you have constipation, one of the first things that you want to do is sort out that constipation. All right. Now this is my absolute favorite part and bread and butter, I guess, of everything is the pelvic floor in relation to a pelvic organ prolapse. So the pelvic floor has many different functions, but one of them is support. Now, the pelvic floor is basically the bottom of our pelvis, and it's made up of a whole bunch of muscles and other tissues, ligaments and fascia, that support all of the pelvic organs. They are responsible for helping to close off the urethra or the rectum for incontinence issues. They are responsible for strength of being able to support and squeeze. They have so many different options. I actually did a talk on kind of the anatomy of the pelvic floor previously. So if anyone didn't see that one and they're interested, please reach out to the clinic and we'll be able to send you a link to that. It got recorded because there is so much going on in that pelvic floor. But the biggest thing that we are going to talk about related to this prolapse is that support piece, because it is working against gravity and against pressure from the abdomen to keep everything up where it's supposed to be. Now, what prolapse is it's that dropping of the organs, which we discussed, but it's putting an intense strain on all of the tissue around it that's supposed to be kind of holding it and supporting it in that place. Now, once ligaments are stretched, and this goes for any ligament in the body, they will remain stretched. If a muscle gets stretched, then it usually comes back. It's quite elastic, but ligaments are a little bit less elastic. And that's why, for example, people who roll their ankles frequently tend to continue rolling their ankles if there's no treatment involved, because those ligaments will be a little bit stretched and they can't hold you where they're supposed to be. But on that same note, if someone sprains an ankle, one of the biggest things that we're doing is we're teaching, or I guess strengthening, the surrounding muscles so it doesn't matter, so that those muscles are able to support the ligaments in through there and everything is hunky-dory. Now, that is what the pelvic floor is doing. If we have a nice, strong pelvic floor, then we're able to support everything and decrease the strain on the ligaments to help prevent or avoid worsening of prolapse or organ kind of shifting. Now, the best way to really visualize that, because that can be kind of a weird thing to think about, is the boat analogy. So basically what we want to do is think of our organs as a ship that's in a dock. So a ship has come in, it has been docked, and it now has guy wires around it or ropes to help it stay where it's supposed to be. So in the first picture in A, we see our happy boat and short little ligaments or ropes and lots of water supporting. So it's creating this nice buoyancy underneath. Everything is hunky-dory, nothing's being strained. If in our second picture, the water goes down, then you lose that buoyancy, you lose that support from below, and that puts a lot of pressure on those guy wires, on those ropes, on our ligaments. So we have that downward pressure without basically an equal upward pressure to support. So these guys get stretched and strained and angry, and that is when we can see some of that shifting. Now, what we want to focus on is getting that buoyancy back so that those little guy wires or ropes don't have the same strain anymore, and you're able to basically reduce that movement, that shifting of the surrounding organs. So that's why the pelvic floor is so, so important in all of this, is it's giving that support. So all of that being said, that is a lot of information to throw at you in 25 minutes, but basically we have prolapse in our society, but when do we really have to care? So if you follow this little diagram, anyone that I see in clinic and do an internal assessment on, we will always be assessing for a pelvic organ prolapse because it is so closely related to most other pelvic issues. Now, I may do an assessment and find, yes, you have a grade 1 or a grade 2 pelvic organ prolapse. There is a chance that you will not have symptoms. In that case, you can make the option of no symptoms, don't care, that's fine. We focus on something else. We focus on the actual issue at hand. But you might have an actual objective, which means actual finding of pelvic organ prolapse, and you have symptoms. You might have that heaviness or that bulging or an organ that is coming out through that vaginal canal. Now, everyone is different when it comes to symptoms. There's a chance that you have those symptoms and you have it sorted. It is not affecting your life at all. You are down here. That is up to you on whether you want to treat it now or ever. But if those symptoms are affecting your life, that is where I come in. So basically, I wanted this slide to say that even if you're having these symptoms, you do not have to be scared. I'm not trying to scare anyone into what could happen, what could be. I'm also not trying to scare anyone into coming to see a pelvic floor physio. But if it is affecting your life, or you discovered that you have one and it might not be affecting your life now, but you want to make sure it doesn't in the future, then that is where some sort of treatment plan will come into play. All right, any questions so far? Doesn't look like it. Perfect. Okay, now there are kind of two main treatment options other than physio. The first one is a pessary. Now, many people might have heard of a pessary if they do have a prolapse or have been kind of talking to someone with it. A pessary is basically like a vaginal or rectal orthotic. So it is something that is placed in, generally through the vagina, but occasionally rectally inside, and it can either be temporary, so it could be something that you just put in when you're running or when you're doing certain activities, or you put in for a vacation because you know you're hiking a lot or whatever, or it can be permanent. And I'm going to put permanent in air quotes because you don't just put it up there and leave it there forever. That is something that you'd have to go in fairly regularly. I think it's every 3 to 6 months to get it taken out, medically cleaned, sterilized, and then put back in. But in those cases, a doctor would actually be doing the insertion. And it all depends on the different grades. This is most commonly used for uterine prolapse because it's coming right down the middle and we can support it from the front. But a lot of bladder prolapse can be basically splinted with this as well, and the occasional rectal. Now, something like this is unfortunately not something you can get at a drugstore or anything like that. It does have to be fitted specifically for you. And if you look at the picture, there are a whole bunch of different types. There's rings, there's cubes, there's slings. This is always an interesting one that kind of supports the bottom of that uterus. And so all of the different types are for different specific situations. So you would go see a medical professional, sadly not physios in Alberta that I know of, but doctors or OBs would be able to fit you, find you the best one, decide whether this is going to be one that gets taken out frequently or if it sticks around there for a few months. And then they would kind of help you through that. Now, this can be very scary for a lot of people. Just the concept of having something up there, but it's something to consider less as a crazy medical device and more as a simple orthotic that allows you to do the activities that you want to do. If this is the bridge for you to get back to being able to go hike or go see people or just not have to worry about things coming out when you go grocery shopping or something like that, sometimes these can give you your life back. So it's just a good idea to know that that is an option that's out there that could be appropriate for some people. The other option that I definitely can't do is surgery. Now, I'm sure a lot of people are on the same page as me that generally we don't want to jump right to surgery, but if it is necessary, again, to try and get your life back, it is still an option. So there are different surgeries for the different types of prolapses. They're all there in big, long, crazy names, but most of them involve sutures. Some of them involve mesh to basically support the organ in replacement of the ligaments or help support the ligaments that are then supporting the organ. Some of them, like this one that's shown for a bladder prolapse, are going in, most of them are through the vagina, some of them are abdominal, but if they're through the vagina, then they generally have to cut a hole in the vagina, do things with the tissue that's around it, and then suture it back up or create support in through that vaginal wall. Now, in that case, then sometimes we can get a little bit of comfort after. Some people will end up with pain with sex or something like that. I'll discuss it on the next slide. So there are kind of some pros that could get you back to life, but there are also risks and some cons. One of the interesting things to note is that with a severe bladder prolapse, sometimes with the surgery, it can cause incontinence for the high grade. So that's, you're looking at your grade 4s where you're in that full inversion. And that's because now, in order to support everything, it puts it in a position where there may be less control. But for some people, that is a win. That could mean that your bladder is inside. You don't have to worry about it coming out when you're doing activity or anything like that. And so a little bit of incontinence is still a massive, like the pros massively outweigh the cons. So all of that to say, surgery is an option. Usually it's not the first option, but if you need it, it's there. And sometimes it's what is going to help you get your life back. A few of the risks are always important to know. Incontinence, like I mentioned, can sometimes be the case. A lot of them, 30% of them in most research are showing that there is a recurrence rate. And that is usually because that same pressure that caused the prolapse in the first place, usually a downward force or kind of poor core stability, not using the full core to its ability. If that is not solved and they fix everything, then there is a decent chance that that downward pressure is going to still continue and put more stress on whatever the new supports are. So we do see recurrence in a lot of cases, but that's where strengthening can come in handy and you can decrease that risk. I'm sure a lot of people have heard the class action lawsuits around the vaginal mesh that is related to this. Now, I like to think that there are options with better mesh, but there is still that risk. Infection is always a risk. Bowel dysfunction can occur, same as bladder dysfunction. Dyspareunia is that painful intercourse that I mentioned, and that is generally when they went through vaginally to do the surgery, or it can be based on where everything is supported. But usually there's options. So if that is the case, you can usually find ways around it. Something I can help with if you need, but there are ways to kind of improve that, but it's still a risk of that surgery and obviously general surgery risks. Okay, this is really where we come in. So pelvic floor physiotherapy and how it can help a POP or a prolapse. Now, these 4 things are basically taken from research and how physio can help with a prolapse. So the number one thing is thinking of that boat analogy again. If we can strengthen those muscles on the bottom of the pelvic floor, then we can create support for those organs, for those ligaments to reduce further stretching. And that is why a lot of studies have been showing, it's really exciting, multiple studies, that behavioral changes, which is usually just an education piece, and pelvic floor exercises can prevent worsening, and for many people can improve prolapse by 1 degree. So I, and hopefully no other physio, is ever going to claim that this can cure prolapse, that exercises, that education, that behavior changes can cure prolapse. But there's a lot of wonderful, proof isn't the right word, but results coming out showing that you can take a grade 2 where it's close to that vaginal opening and lift it up a little bit more, just so it's kind of in the canal, but you barely even notice it. Or a grade 1 can no longer be something that's even noted. Grade 3s, you can sometimes get them back internal, which is a huge change. So by adding that support, by adding that strength, you're reducing that strain, but you're also hopefully helping to lift things back to where they should be and hope to, I guess, maintain that as you go forward. Now, something else that we can do is basically help all those other things that are related to prolapse as well. So incontinence and urgency, frequency of urination, those can all be either improved or resolved, whatever, by doing other pelvic floor physio. So by improving associated issues, you can help with the general symptoms of that prolapse, hopefully to a point where you don't even really notice it. Some other really exciting research that came out was that adding pelvic floor physio to pessary use seems to be better for people for overall prolapse than using the pessary alone. And what's really interesting is sometimes based on your situation, we may be intentionally doing exercises with the pessary. The pessary might get everything into place, and then you do your exercises there so that you are basically doing them with the best form. It's like adding a little bit of a lift under a heel when doing a squat. It's putting you in really nice form so you can get the best strength from everything. So those pessaries seem to work really, really well with pelvic floor physio, and it can either help improve it or help it not to worsen as you continue on your way. Now, a lot of research is showing pelvic floor PT is now being recommended as that first line of management prior to other options, especially surgery. And that is because we're going back to what I mentioned before, there is a fairly high recurrence rate. And that's because if you don't change anything and you have the same stress, your body's going to go through the same thing again. So going through the surgery, getting everything into a really nice position, everything supported, and then strengthening under that can really decrease the chance of recurrence, but it can also decrease the chance of even having to get surgery in the first place or having to go down the pessary route or whatever. So a lot of medical communities are now recommending, I'm saying pelvic floor PT exercises, appropriate exercises as the first line of management, along with an education piece. So what would that actually look like? I had to add this in as something fun since you've been looking at a lot of pelvic organs. But basically what would happen in a pelvic floor session is we would go through assessment first, obviously, if that's the first day, or if I've seen you before, we might be doing kind of reassessments, looking at strength and tension internally. Now, I should take a step back. There's a lot of stuff that goes on before the internal portion. We would chat about symptoms, figure out what life looks like, how much is this affecting, when are you noticing symptoms, do we have other related things, do we have bowel issues, just kind of going through a big, long, overarching piece subjectively or what you are reporting. Then there's probably some sort of external component as well. Then we get to internal, and that's what I'm talking about here. So we would go in with 1 and 2 fingers vaginally, sometimes rectally if necessary. And I'm going to assess the strength of the muscles. We're looking at the strength side to side, the strength front versus back. Can you hold it? Is there a quick strength? Are you able to do repeated? There's a whole bunch of different testing, the same way we would test any other muscle group in the body. And I'm also looking for tension. Again, same as any other muscle group. I'm going to be poking those muscles just a little bit to see if there's any tenderness, if I'm noticing any kind of feedback coming out. Is there tension? Because we know that pelvic floor tension can very much cause or wreak havoc in through that pelvis as well. I'd be assessing those things. Then we assess for prolapse. And what that involves is you would be kind of on your back, on your arms, and then you would bear down, cough, create downward pressure. And then I am observing what is going on. So we're looking at what organ is coming in, if any, and how far along is it. Now, for some people, we do have to go into kind of a standing position or sitting position if we're not getting the same basically results or noticing the same prolapse that you normally notice. So I know I had an absolutely lovely patient, and her symptoms or what she experiences on a day-to-day basis never seemed to show up when I was assessing on the back. So we had to do the first little bit with her standing up just while we were chatting. And then once she jumped on the bed, we'd assess it really quickly so that everything would be out the same way it was. So there's ways around it. If you only notice it in a certain position, we might assess in that position, just trying to figure out what the heck is going on and what you are experiencing. Then, yeah, I noted possible rectal assessment. We only do that if it's going to be related or if we're trying to really get a really broad picture. But for some people, it is not totally necessary, so don't let that scare you away. Now, once that is done, treatment is based on that specific assessment. So almost always there's going to be an education piece. This presentation is helpful because you kind of have an idea of what's going on, but there's going to be kind of lifestyle management stuff that we'll probably discuss. Then pelvic floor exercises are going to come into play. And that is based exclusively on what we saw in assessment. So are we working on strength? Are we working on endurance? Maybe you have great strength, but you can't hold it for very long. So if we can't hold it for very long, how is that pelvic floor supposed to be supporting the organs from the bottom all day, every day? So we might be looking at endurance. The front of your pelvic floor might be weaker than the back of your pelvic floor, or vice versa. So we'll be doing specific exercises trying to target where the issues are kind of coming from. Then, and I promise you, if we don't do it on the first day, it's coming on the second day, we're connecting the pelvic floor to a central stabilization complex, or the core. So I'm going to go into, in one of my future lectures, the connection between the pelvic floor and the rest of the core. But basically, in 30 words or less, our core is made of our diaphragm up top, some abs and back muscles, and then our pelvic floor on the bottom. And if we're not using that correctly, then instead of it working as a piston and going back and forth, it just goes down. And there's nothing at the bottom that's coming back up. And so it's creating this frequent downward pressure. So there's almost definitely going to be some connection of the pelvic floor to the rest of that core complex in treatment. We'll also be treating other stuff, especially constipation. Again, if that's something you're dealing with, please go get it sorted out, because then there's going to be decreased downward pressure and aggravation. We may discuss a pessary if I think it's appropriate, and always going through pros and cons for you. You never have to do anything that you're not comfortable with. And also a few quick fixes. So things that we can start to do right away. And those are what I wanted to go over with you, so you can kind of take a few little nuggets from today right away. So lifestyle modification is the first thing. If you are experiencing a lot of heaviness, especially if you're noticing bulging or tissue coming out, then we want to decrease impact of activities right away. And that's because if we're thinking of that boat, if all of a sudden you took away the water and then someone is jumping around on that boat, you are going to create even more pressure through those ropes, and that is going to lengthen them, it's going to weaken them, and it's going to make matters worse. So just because you have prolapse doesn't mean you can't jump anymore, ever, but you usually want to take it out and then reintroduce if it's appropriate down the road. Offloading breaks are also a really, really nice thing to do throughout the day. And that's because as your day goes on, gravity is going to be basically affecting those organs more and more. So if you're able to take some breaks throughout your day where you either sit down or lie down on your back, that would be amazing. Then we can let everything settle back to where it wants to be, get those ligaments nice and happy, give those muscles a little bit of a break, and then you can kind of start back at square one as you go through the rest of your day. So usually I'm recommending some sort of offloading breaks if it's becoming an issue throughout the day whenever you can. We also want to improve constipation. That's what the third or fourth time I've said that. We want to reduce that downward pressure, that's that pushing down feeling. If you're having any issues with bowel movements, you're going to want to get that sorted out, whether that's with naturopath, dietitian, doctor, whatever, in order to just take away that aggravating factor. An activity or exercise that you can do right away too is calves on a stool. And this is a really lovely one. It's a really great position actually for back pain as well. So a lot of my back pain patients, if you're on here, you've seen this, something similar, at least this position before. And basically what you're doing is you're lying on the ground with your calves up on a stool so that hips are at 90 degrees and knees are at 90 degrees. She's using towels. That's lovely. Give yourself whatever comfort you need, but this is the most important part. Then you can grab two balls, and I'm saying like, what are they called? Stress balls, like a foamy stress ball, not like a really hard lacrosse ball or something like that, but little stress balls, and you either put them under the buttocks, under the PSIS, which is basically just above and to the side of the sacrum, so kind of upper bum, or one over the sacrum, whatever is comfortable. And that's going to help you with tilting. And so what you would do is basically pull that pubic bone up towards your sternum, up towards that belly button, really slowly, and then hold it if it feels good. And then going back down and fully relaxing. No one can see it, but I'm doing it in my chair right now. I can't not. And so what's happening is you're basically shifting that pelvis under, like you're tucking your tail, and then letting everything come back. This is a really relieving position for the pelvic floor, the pelvic organs. This is actually a wonderful thing to do, position and movement, for people who have really painful periods. It can be helpful for a lot of people. Basically, we're just trying to relax everything in the area and let everything settle where it's supposed to be. So I say here, repeat for 5 to 10 minutes. That doesn't mean you're moving for that whole 5 to 10 minutes, but maybe you're doing 5 to 10 and then you're relaxing. Bring a book, bring your phone, bring a tablet, hang out in this position, because it's going to really take pressure off of everything, the organs and the ligaments, hopefully decrease your symptoms right now and give you a really nice springboard for doing future appropriate exercises so that everything is where it's supposed to be. Now, I always say floor and chair or couch, but you can always do this on a bed too, because if you have back pain or knee pain or anything like that, sometimes it can be really hard to get to the floor. So if you just stack up enough pillows that we can get at least close to this position, you can get very similar effects as well. Okay, so that is a lot of information. These talks are always crazy because I'm trying to fit in enough that people can step away with some sort of new knowledge or control or independence over their body. But I also hope that I didn't overwhelm you too much. But basically, if you ignore me for the last 45 minutes and just want all of the information, it's on this slide. So prolapse, when we're diagnosed, is actually called pelvic organ prolapse. And that's basically the bladder, the uterus, or the rectum pushing into that vaginal space, not through the vaginal wall, but into the vaginal wall, and the whole thing is coming with it. There are different grades based on how far it's protruding into that vaginal canal, and include anything from a little bit of movement to full inversion of the organ outside of the body. Now, it can affect anyone, but it is definitely greater in people who have had babies, whether that is vaginally or cesarean. But even if you haven't had it, there is a chance, or haven't had kids, there is a chance that you can still be dealing with this, and there are things you can do about it. Symptoms, things that you're going to be noticing are the heaviness in through that perineal region, that lower pelvic region, bulging, or some sort of protrusion or something in the way on insertion, that feeling of downward pressure, or you might be getting bowel or bladder symptoms that are then related to that prolapse. Basically, what the pelvic floor is doing is it is supporting everyone. I like this picture. We have our happy little pelvic floor, but he's asking how long do we need to hold these up? And the answer is always. But basically, it's a hammock. It's a support for those organs, keeping everything in place, just like water under a boat. If we lose that strength, then we get more strain on the surrounding tissues. Treatment for prolapse can involve pessaries, which are those kind of internal orthotics. There is surgical options, but pelvic floor physio is by research recommended as that first line of defense, just to try and get that pelvic floor nice and strong, or considering behavior modifications and other things as well, those little tidbits. And using the pelvic floor appropriately is the most important thing. So we always want to be making that connection with the brain, so the brain knows how to use it so it can support everything. And then everything will be happy and in place. So that is all the information that I planned on sharing today. I'll ask questions in a minute, but here's my happy vagina. He's nice and strong. I do encourage anyone to reach out. These are topics that don't get talked about. There's a lot of times, even some kind of mom to mom, you might talk about like, oh, I dribble when I laugh or something like that. It's not as frequent that people are openly talking about the fact that there's something coming out of their vagina, or that they are getting that downward pressure. So please, number one, feel free. You should be getting a link to this lecture. Feel free to share it with anyone who could benefit from it. The more people that understand that that is out there, the better. The reason I got into pelvic floor physio in the first place was I just realized that the general public does not have this information. And there's so many things that are out there that we can help with. So I encourage everyone to kind of use that information, share it with anyone that you know. And if you have further questions, please contact me. I have no problem setting up a quick phone call if you're not sure if pelvic floor physio is appropriate, or if you just have a quick question. You can also email me. That's my direct email at work. I have no problem answering basic questions. Sometimes I will be honest if I do think that it's hard to answer without an assessment, but I'll never pressure anyone into an assessment. My goal today is so that more people know what's going on and can basically have control over their bodies and their situations. So reach out if you'd like. And now, if anyone has any questions, feel free to throw something into the chat. Renee, is there anything?
I don't see any questions, but I love the normalization that you created in this conversation. Very much appreciate that. Lots of information coming at me that I was completely unaware of.
Right?
Yes, and personally coming from a C-section rather than a vaginal birth, I thought, well, no, this isn't a situation that I would have, but there are checkpoints that make me think, oh, there is a possibility. So I appreciate the delivery of your speech. I think we can all give Ellen an amazing applause. Everything that you said was so well articulated. Does anyone have any questions? I'm not seeing anything in the chat. Other than gratitude, because that was a great talk. Thank you so much, Ellen.
Of course.
And if we don't have any more questions, I think we would love to say have a great evening to everybody.
Yes. Have a lovely time, and hopefully you'll come to the next one in about a month.
Yeah, sounds great. And we will be sending a follow-up email with this entire lecture on a link, probably within the next 48 hours. So look for that in your mailbox if you do want to pass it on to a friend or review it again. Okay. Thank you, everyone.
Thank you, Erin.
Bye.
Bye-bye.